Hello, my name is Arvind Rajamani. I'm an intensivist working at Nepean Hospital, and as part of the SAFE course for the fellowship exam, I'm going to talk on blood gas analysis. Part of this talk will also be given by Dr. Carton Costello, who's one of my friends from St. George Hospital. He's an intensivist working at the St. George Hospital. Blood gas analysis is something that is very important and crucial to intensive care management, and it's just surprising that there is still a reasonable amount of discomfort surrounding it. One of the advantages of the blood gas analysis is that it's highly mathematical and numbers don't lie. And perhaps that's where the discomfort lies as well. So part of the process here would be to debunk some of the myths and to make it simpler. Now, another thing that I want to go straight up is there's been a lot of controversy over the past couple of decades about the best approach for blood gas analysis, with some people saying that the conventional Brownstedt-Lowry theory is good, and some other people saying that the Stewart approach is better. The reality now is that in the past 10-15 years, the two systems have come very close together, and there's hardly any difference between the two. And what I'm going to be teaching here today is predominantly the traditional approach, which is the Brownstedt-Lowry theory. And if you want a specific detailed approach on the we'll also be covering the Stewart approach to some extent, but if you want a very detailed analysis of the Stewart approach, we'll point you towards other resources. So let's go on. My stepwise approach to blood gas interpretation is reasonably simple. And this is something that I generally teach, and it works for me. So if you have something else that works for you, that's fine. I'll just give you what works for me. I first look at the pH in order to determine whether it's normal, whether it's acidotic or alkalotic. Then I determine whether there is a respiratory component or whether there's a metabolic component. And for the respiratory component, I look at what the carbon dioxide is doing, and for the metabolic component, I look at what the standard base X is doing. Then I find out if there is compensation, and I'll just talk to you about compensation in the next few slides, and I'll skip it for just now. So once I've determined whether it's a respiratory or a metabolic problem, my next priority is to find out what the anion gap is. The anion gap must always be corrected for albumin. So you always have to use the corrected anion gap, not just the raw anion gap that you get. So once you get the corrected anion gap, you then determine whether the anion gap is high or normal. If it's high, I additionally go ahead and do the delta-delta ratio, and sometimes I use the Stewart equation, and then always the osmolar gap. If I get the measured osmolality to determine whether whether there is an osmolar gap, and I do that in some specific instances when I can't explain things. On the other hand, if the anion gap is normal, then I do a urinary anion gap in order to determine whether or not the kidneys are the culprit. Okay, so to summarize, first look at the pH, then determine whether it's respiratory or metabolic. Compensation is a slightly side issue. I then determine what the anion gap is and correct the anion gap for albumin, and use the corrected anion gap to determine whether it's high or normal. If it's high, I get the delta-delta ratio and sometimes the osmolar gap. The Stewart's equation is something that I do not use personally, but a few of my colleagues do. If the anion gap is normal, then I get the urinary anion gap. Now, compensation is the body's inherent defense against metabolic derangements, and the body tries to restore the metabolic homeostasis.
which means that compensation always occurs by the opposite limb of the homeostatic system. Now, what are the two opposing systems, or I shouldn't say opposing systems? What are the two contributing systems to blood gas or metabolic systems? One is the respiratory limb, and the other is the metabolic limb. And compensation always occurs by the opposite limb of the homeostatic system. So if you have a primary metabolic problem, then you'll have a respiratory compensation, and vice versa. The rule of thumb with compensation, as far as whether it's occurring or not, is that the bicarb and the carbon dioxide must always move in the same direction if there is compensation occurring. I repeat. So I'll give you an example. If you have metabolic acidosis, then the primary problem is that the bicarb has fallen, and the compensation by the lungs results in a lowering of the carbon dioxide, which means that if you have compensation, then you'll have both a fall of the bicarb because of the primary problem and a fall of the carbon dioxide as a result of compensation. If you have a respiratory acidosis, for example, then what happens is the primary problem is that the carbon dioxide has gone up, and if you have an adequately compensating metabolic system, the bicarb also goes up. So if there is compensation, the bicarb and PCO2 must always move in the same direction. And if they do not move in the same direction, so when one of them is high and the other is low, or when one of them is high and the other is normal, then it means that compensation has not occurred. Now, once you have determined that compensation has occurred, you'll then want to know the extent of compensation, which is compensation occurring to the full extent or to the maximal compensation? And there are some problems with understanding the extent of compensation. There is a common myth there that if you have maximal compensation, then the pH must have become normal. This is wrong. Okay. Now, the pH returning to normal or not depends on the extent of the primary problem. If you have such a bad metabolic acidosis that despite the patient breathing down to a PaCO2 of 5 millimeters of mercury, the pH is still low, then it's not a problem of the lungs, it's not a fault of the lungs. The lungs are compensating maximally, but the extent of the primary problem is so severe that despite the maximal compensation by the lungs, the pH is still abnormal. Okay, so remember that there are inherent limits to maximal compensation for each organ system. So that's the first thing. Do not believe that the extent of compensation is not defined by whether the pH is normal or not, but it is defined by whether or not the maximal limits have been reached or not. And for this, we have some rules of thumb.
So what are these arbitrary? What are these rules of compensation? Okay. Now this is a very busy slide, and it essentially divides. This slide is actually divided into the 4 common acid-base problems, primary acid-base problems: metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Now, in metabolic acidosis, the compensation is happening by the respiratory system. So there is respiratory compensation in metabolic acidosis or alkalosis. Okay. On the other hand, in respiratory acidosis and respiratory alkalosis, the compensation is happening by the metabolic limb, so by the kidneys and by the other organs. So the one important thing to differentiate between the two levels of between the two compensatory mechanisms is that in primary respiratory problems, the initial compensation by the kidneys in particular, so the metabolic compensation, is quite suboptimal, and then the efficiency of compensation slowly starts improving and reaches its maximal limits in roughly 24 to 48 hours. And therefore, there are different rules for acute and for chronic. Okay. On the other hand, when you have a primary metabolic problem, the respiratory compensation starts reaching maximal limits from the minute 1. So the compensatory ability is unimodal. It doesn't have that bimodal compensatory ability. Okay, so you don't have to remember too many things about that. So there is no such thing as compensation for acute metabolic acidosis and chronic metabolic acidosis. The respiratory system, the lungs, just behave the same way. Okay. So let's now go to each problem and so in summary, for the rules of compensation, for primary metabolic problems, I really like this simple and easy to use rule of compensation. When there is complete respiratory compensation for primary metabolic problems, the last 2 digits of the pH will be approximately equal to the PaCO2 in millimeters of mercury, plus or minus 5 millimeters of mercury. So the last 2 digits of the pH will be approximately equal to the PaCO2. We also have some numerical rules of thumb for compensation, for complete compensation. Okay, and let's see these here. Firstly, for primary metabolic acidosis, the respiratory compensation rule is 10:12.5, which is for every 10 millimoles drop in the bicarb, the patient hyperventilates to the extent that the carbon dioxide falls by 12.5. So for every 10 millimoles drop in bicarb, the carbon dioxide drops by 12.5. For metabolic alkalosis, for every 10 millimoles rise in the bicarb, the carbon dioxide, the patient starts becoming apnea, hypoventilating, and the carbon dioxide rises by 7. So it's 10:7. So 10:12.5 for metabolic acidosis, 10:7 for metabolic alkalosis. For respiratory acidosis, in the acute stages, it's 10:2, which is for every 10 millimeter rise of PaCO2, the bicarb increases by 2 millimoles. For chronic, it's 10:4. For every 10 rise of PCO2, the bicarb rises by 4. For respiratory alkalosis, it's almost similar. Okay, in the acute stages, it's 10:2.5. You can say, it's 10:2. So you can have virtually the same rule for respiratory acidosis and for respiratory alkalosis. And all you have to therefore remember is this thing here, 10:12.5 and 10:7. Now is the time to deal with the business end of the blood gas analysis. So these are the most important things. We'll deal with some of the metabolic abnormalities, and that means anion gap, delta-delta ratio, and other things. Then there are a number of patients who come with complicated acid-base problems. They have not one simple acid-base abnormality, but they have a combination of several acid-base, so some acute on chronic or even acute on acute and so on. And then we'll talk a little bit about the strong ion difference and how it might, and about some of the controversies in the approach between the strong ion difference between the Stewart's approach and the conventional Brownstein-Lowry approach. Anion gap. Okay, now this is vital in the Brownstein-Lowry approach. This is absolutely vital. First of all, we'll try to understand what this anion gap is all about. In the blood, there are normal cations and there are normal anions. The cations include sodium, potassium, calcium, magnesium, and so on. The normal anions include all of these, so chloride, bicarb, sulfates, phosphates. I haven't mentioned albumin here, which is also an anion. And in you and me, in the blood, there's actually no gap between the cations and the anions. Imagine if there was a big gap between the two of them. Every time I touched you, I will get an electric shock. That doesn't happen. So our blood is actually electroneutral. So what is this whole concept of this so-called anion gap? It's a measurement problem. It's a measurement gap. It's a laboratory feature. So during the measurement, we only measure some of the anions. We do not measure other anions. So the sulfates and the phosphates may not be measured. We mainly measure the chloride and the bicarb. And that means that we measure more cations than we do anions. And that results in fewer anions in the blood, in the measurement in the blood sample than the cations, and this therefore results in an artificial gap in the measurement, and this is called the anion gap. Okay. So how do you calculate the anion gap? And if you see here carefully, I've mentioned the word calculation of the uncorrected anion gap. You'll understand the significance of this after a few slides when I talk of correcting the anion gap for albumin. But for the moment, for this slide, we'll just talk about how you calculate the crude anion gap or the uncorrected anion gap. And that's very simple. All you have is a measure of it's the sum of the measured cations minus the sum of the measured anions. What are the measured cations? It's sodium plus potassium minus chloride plus bicarb, and the normal reference range is about 12 to 20 millimoles per liter. However, some people who are lazy, that includes me, do not include the potassium, and we just take the sodium minus chloride plus bicarb, and now all of a sudden you have to take off. Usually the potassium is about 4, and the reference range now is 8 to 16 millimoles per liter. Okay. Also note that the chloride assay has changed over the past few years in various labs, and therefore the reference range for the chloride may be different for each lab, and if the reference range of the chloride is different, the anion gap is going to be different. So each lab may have its own anion gap reference range, which means that you'll have to take your lab's reference range into account when you're using this for analysis. Now the correction for albumin. This is crucial, very crucial. I can't underemphasize this. Albumin in the blood exists bound to several amino acids. Typically, it exists as an anion. Okay, it can exist as a cation as well, but typically albumin, the sum total of albumin is as an anion, and therefore, and in fact, albumin is the numerically most important unmeasured anion. The reference range of the anion gap, the 8 to 16 or the 12 to 20 or whatever, that reference range is calculated assuming an albumin concentration of 44 grams per liter. So, okay, for simplicity, I just keep it as 40 grams per liter. So, you assume that the albumin is 40 when you say that the anion gap is, the reference range is 8 to 16. If your patient has hypoalbuminemia, all of a sudden, that patient's anion gap is, the reference range is going to change. So you have to correct for hypoalbuminemia. And how do you do it? For every drop of albumin by 10 grams per liter from 44, or for simplicity I keep it as 40. For every drop of albumin by 10, you have to add 2.5 to the uncorrected anion gap, and this gives you the albumin corrected anion gap. I repeat, for every drop of albumin by 10, you have to add 2.5 to the anion gap. For example, if the albumin is 24, it's dropped by 10 and 10, so it's dropped by 20, you have to add 2.5 plus 2.5. So whatever anion gap you get, the uncorrected anion gap, you add another 5 to it, and that is the true anion gap for the patient. That corrected anion gap is the one that you have to use for your analysis. Okay. Now, how do you use the anion gap for acid-base analysis? First of all, it is vital that you calculate the anion gap for every single blood gas. Every single blood gas. Do this even when the pH is normal or the base excess is normal. It does not matter. Every single blood gas you have to calculate the anion gap, the corrected anion gap, okay, corrected for albumin. And it's the albumin corrected anion gap that you have to use for subsequent analysis. What are the common anion gap patterns? The common pattern is actually only high or normal anion gap. But rarely you can have a low or negative anion gap. So let's talk about the pattern analysis of the anion. So let's start off with the very uncommon or rare thing, okay, negative anion gap. And I just want to finish off all these uncommon, bizarre things before getting on to the really meaty stuff about the high anion gap and the normal anion gap. Okay, so just because I do this first, don't think it's common. It's absolutely rare. You're hardly going to see one in your life. Usual cause of a negative anion gap is severe hypernatremia or some cause of pseudo hyperchloremia. It's a lab error. That's the most common cause of negative anion gap, a lab error. When can you see pseudo hyperchloremia? When you have severe hyperlipidemia, then salicylate intoxication is known to cause an alteration of the permeability of some ion specific electrodes, and it can cause pseudo hyperchloremia. Bromide ingestion. I used to think that bromide causes a negative anion gap because of the negatively charged ions. No, it's not. Actually, bromide confuses the ion specific electrodes, and the ion specific electrode starts thinking that every bromide ion reacts like 3 chloride ions. Okay, so what happens is a bromide concentration of just 5 millimoles per liter will translate to a chloride concentration of 15 millimoles per liter. Okay, so suddenly you have a pseudo hyperchloremia, okay, which doesn't exist in the patient, and that causes a negative anion gap. Now, is this important? Previously, bromide used to come as a diluent along with the as a salt for several over-the-counter medications. That's no longer the case, and perhaps the only medication I believe that's still sold with bromide as a salt is pyridostigmine bromide for myasthenia gravis. I really don't know. I haven't seen any case, and if anyone has seen a case, there's my email address. Please email me. Low anion gap. This is the next thing, again uncommon. Therefore, let's finish it off and move on to the meatiest thing. Hypoalbuminemia causes low anion gap, but you're going to correct for it. Okay, you have the correction factor. For every drop of 10 from 44, you add 2.5 to the anion gap. So that takes it out of the equation. Severe normal anion gap metabolic acidosis or the hyperchloremic acidosis can cause a low anion gap. And when you have an increase in the unmeasured cations, okay, so when you have severe hyperkalemia, severe hypermagnesemia, and if you have a lot of plasma proteins, IgG plasma proteins in multiple myeloma, or you've given somebody IgG because for immunoglobulins for any of the neuromuscular conditions, Guillain-Barré or myasthenia or anything like that, then you can have a low anion gap. Okay. Now, I really don't know how important hyperkalemia and hypermagnesemia are in the equation, because just think about it. When you have a potassium of 8, you die. So, you're really not going to lower your anion gap. And if you did do it, then it's a nice post-mortem biochemistry. Patient is dead. So now we come to the most important bit of all, which is the high anion gap. We also have the normal anion gap, which we'll cover in the end, but the high anion gap is the most important component of the anion gap. It's the most common pattern of the anion gap. And the good news about high anion gap is, so for this you have several acronyms. Okay, I know of many. The one that I like using is this thing called Mud Sleepy. This was given to me by someone, and what I have done is taken it on and added letters to it. And what you will find is you will also keep adding letters to this. Okay, so regardless of which acronym you use, remember that your list of high anion gap acidosis will never be complete and it will never be comprehensive. But this has served me well. And what do the letters stand for? You'll find that automatically there are a few alcohols. So this methanol, ethanol, ethylene glycol, propanol, you can add another P to it, propylene glycol. Now these are all alcohols and they all cause a high anion gap metabolic acidosis. Then you have the usual suspects. You have renal failure, okay, uremia, so ketoacidosis, lactate, then to salicylates and so on. Then in children, iron intoxication can be an important cause, and INH is isoniazid. And I would have said isoniazid, what the hell, I don't, but just 2 months ago I've seen a patient with isoniazid induced metabolic acidosis. Okay, and admittedly it's actually not isoniazid, it's actually lactic acidosis. It causes lactic acidosis, and when you have lactic acidosis in the absence of shock, so type B lactic acidosis, you have to think of all the causes of type B lactic acidosis, and INHS, isoniazid is part of it. But I like my vowels. I like adding to the list of vowels, so it makes the acronym flow nicely. Then you have all these esoteric things. Then you have some rare things like paraldehyde, pyroglutamic acid, and paraquat, and so on. And pyroglutamic acid is something worth mentioning. When you have a patient where you have an unexplained high anion gap metabolic acidosis, go and ask for a history of chronic paracetamol ingestion, and you may be missing a case of pyroglutamic acid. The paracetamol levels will not be high, will not be in the toxic range. Okay, need not be in the toxic range, but this could just be repetitive chronic paracetamol poisoning. So that's my list. Okay, if you guys add to the list, that's my email address and you can send it to me. Now you come to the next thing. This is something which confuses people no end. Okay, and this is arguably where the Stewart's equation is actually inherently better than the Bronsted-Lowry theory approach, but the modified approach that we are using now is good enough to diagnose it. What do you mean by mixed disorders? Mixed disorders are when you have a combination of primary acid-base abnormalities. So the same patient having a metabolic acidosis on top of a metabolic alkalosis on top, and then a respiratory acidosis, that kind of thing. Okay, or the same patient having a high anion gap metabolic acidosis and a normal anion gap metabolic acidosis. So this, the patient has had diarrhea, has had lots of bicarb loss from the stool, and therefore ends up having a normal anion gap metabolic acidosis. Or a patient with renal tubular acidosis having a normal anion gap metabolic acidosis. But the same patient also is diabetic and has developed a ketoacidosis. So he now has a high anion gap metabolic acidosis over and above his normal anion gap metabolic acidosis. Nothing stops him from getting that, does it? So how do you diagnose this? And for this, when you have patients with high anion gap metabolic acidosis, you can use the delta-delta ratio and the Stewart's approach. And when you have a normal anion gap metabolic acidosis, you use the urinary anion gap and the Stewart's approach. So let's see how we go on and do it. So first of all, the delta-delta ratio. Now this is the subject of a lot of angst. Okay, and it's given me quite a lot of grief. And if you think about it, it's actually quite a simple ratio, quite a simple concept. And I think that the real reason why we are so uncomfortable with it is because it involves maths. Now we are doctors and we don't really like mathematics, or at least I don't, and that's why I became a doctor. So what is the maths of the delta-delta ratio? Firstly, very simply, it's a ratio, which means there is a numerator and there's a denominator. Second, there's a delta and a delta, which means both the numerator and the denominator involve differences, which is something minus something divided by something minus something. So what is it? The numerator is the patient's anion gap minus the reference range anion gap, so the normal anion gap of your lab. The denominator is the normal bicarb for your lab minus the patient's bicarb. So it's the difference, the deviation of the anion gap from normal divided by the deviation of bicarb from the normal. That's all there is. Now this is to be done in high anion gap disorders. And sometimes when it's done in normal or low anion gap disorders, you end up having this situation of a negative symbol. So, if the patient's anion gap is lower than 12, then you'll obviously have, if it's say 6, then 6 minus 12 is minus 6. Okay. And obviously that will result in a negative ratio, and people get, how can that be? It's not meant to be done in normal anion gap disorders. It's mainly meant to be done in the high anion gap disorders. And why should you do it? It is to diagnose an additional acid-base problem. Example, if the patient has a normal anion gap, a high anion gap metabolic acidosis because of lactate, then that same patient can have an additional normal anion gap metabolic acidosis because of, say, diarrhea and loss of bicarb from the stool, or pre-existing renal tubular acidosis, which is a pre-existing normal anion gap metabolic acidosis, or the patient can have an additional metabolic alkalosis. For example, a COPD patient on steroids with a baseline bicarb of 40 can come now with lactic acidosis from bowel obstruction or some perforation or something. So when you have a dual effect in a patient with a high anion gap metabolic acidosis, then this helps to determine what that second acid-base disorder is. The simple concept for delta-delta ratio is that when you have a rise in an unmeasured anion, so we'll take lactic acidosis as an example. When you have a rise in lactate, it means that the numerator is going to increase. So if you have a rise of lactate by 1, then the numerator is going to increase by 1. What happens to this lactate in the blood? In a very simplistic one buffer system, so lactate is buffered by bicarb. That is actually not correct. That is not fact. But let's assume that for the purpose of understanding the delta-delta ratio. So if you have a very simple system in the blood where every excess lactate is going to be buffered by a bicarb, whenever for every 1 millimole rise of lactate, there will be a 1 millimole fall of bicarb. So there will be a matching fall of the bicarb. Therefore, for every rise of the numerator, there will be a fall in the denominator. Therefore, the ratio of one versus the other will always be maintained at 1. And if this is not matched, if you have either the rise or the fall is not matched, the ratio suddenly becomes different and it becomes either more than 1 or less than 1. That is the concept. Now, when will the decoupling of anion gap and bicarb happen? It can either happen when, in addition to the high anion gap metabolic acidosis, there is an additional loss of bicarb, which is an additional normal anion gap metabolic acidosis, which is essentially HAGMA plus NAGMA, or when there is an unrelated gain in the bicarb, that is, when you have a HAGMA, that is a high anion gap metabolic acidosis, plus an additional metabolic alkalosis. Okay, so these are the two main situations where the anion gap, the high anion gap, does not get matched or gets decoupled from the fall of bicarb. So let's take each of these. So let's take the first example. Okay, when you have a combination of high anion gap metabolic acidosis plus normal anion gap metabolic acidosis, which means that you have two separate sources of loss of bicarb. Let's take an example. Now, if the anion gap is high, it's 22 in this instance, in this patient, and that is mainly due to a lactate of 10. If this was the only disorder, then first of all, each lactate molecule will be buffered by one bicarb molecule. This therefore results in the bicarb falling by 10. So from 24 to 10 is 14. That expected delta-delta ratio, if this was the only acid-base disorder, will be 22 minus 12, okay, because anion gap is 22 and the normal anion gap, we know the reference anion gap is 12. So 22 minus 12 divided by the normal bicarb of 24 minus the patient's bicarb of 14. So it's 10 by 10, which is 1. But this patient has an additional process of loss of bicarb because of the, let's say he has renal tubular acidosis. So he has another urinary loss of bicarb in addition to the bicarb that is lost because of the buffering. So what happens? Because of the renal tubular acidosis, his bicarb has decreased by a further 5. So the final bicarb for him is not 14, but it's 14 minus 5, which is 9. So what happens to his ratio? The actual delta-delta ratio in him is, anion gap is still 22. 22 minus 12 divided by 24, which is a normal bicarb, minus 9. So it's 0.6. So it's lower than normal. Okay, you expect it to be 1, but it's actually much lower than 1. If you have, what's happened here therefore is the bicarb loss being greater than expected has resulted in the denominator becoming larger than expected, okay, and therefore the ratio has become smaller than expected, a lower ratio. Now let's take the other end of the spectrum. So a patient with a high anion gap metabolic acidosis because of lactate, for example, but he has an additional metabolic alkalosis. Okay, so let's see an example. His anion gap is 22 because of the lactate being 10. Okay, fine. Now, as usual, each millimole of lactate is now being buffered by 1 bicarb, and therefore the bicarb has decreased by 10 from 24, and so it's 14. So it's all good so far. The expected delta-delta ratio, just like previously, the expected ratio is 1. But because this patient has an additional metabolic alkalosis, for example, maybe he was a COPD patient and the CO2 retainer, and therefore his bicarb is not 24, but his bicarb starts off as, say, 29. His baseline bicarb is 29. So what's happened? His baseline, because his bicarb has actually increased by 5 from 24, the bicarb for him, the final bicarb is 19. Okay, now the bicarb has actually not fallen, so it's not 24 minus 10, which is 14, but it's 29 minus 10, so the lactate is 10, so it's 29 minus 10, so the final bicarb is 19. It's higher. The actual delta-delta ratio therefore is 22 minus, so about 10 divided by 6, because this difference in the denominator is much lower than expected. So the actual delta-delta ratio is not 1, but it's 1.6. It's higher. So the bicarb loss being smaller than expected has resulted in the denominator being smaller than expected, and the ratio therefore being higher than expected. Okay, now I always, when I have to work this around, it's not intuitive, it's not, because it's maths, you know. So the bottom line therefore is that the delta-delta gives you a clue about the bicarb. If the delta-delta ratio is lower than expected, the bicarb is lower than expected, which means there are two sources of loss of bicarb, which means this is a high anion gap plus a normal anion gap, metabolic acidosis. On the other hand, if the delta-delta ratio is higher than expected, the bicarb is higher than expected. So all you have to do is this: delta-delta tells you about the bicarb. If it's lower than expected, the bicarb is lower than expected. If the delta-delta ratio is higher than expected, the bicarb is higher than expected. And in the second instance, it means that there is a combination of a metabolic alkalosis over and above the high anion gap metabolic acidosis. One question is, what happens in a patient who has two separate high anion gap metabolic acidosis sources? So the same patient who has a combination of diabetic ketoacidosis plus lactic acidosis, or a patient who has diabetic ketoacidosis plus renal failure. Now, the delta-delta ratio itself must be accurate, because, you know, the anion gap has increased by whatever factor, the bicarb has also fallen by the same factor, so the delta delta ratio must be accurate. Now in this instance, in the case of only in the case of lactic acidosis, not in any other thing, in the case of lactic acidosis, if you want to diagnose an additional high anion gap metabolic acidosis, you can look at what is called the lactate gap, which is so for example, if we take our previous patient, the anion gap, if the lactate is 10, then you'll but the anion gap for some reason is not 22 but it's 32. Clearly the lactate of 10 is not able to account for that anion gap of 32. Okay, you have to have some other process going on, and you'll have to think of other causes of high anion gap metabolic acidosis. Okay, so the bottom line for the delta delta ratio is that it tells you about the state of the bicarb, and just remember this sentence here. If the delta delta ratio is lower than expected, the bicarb is lower than expected. If the delta delta ratio is higher than expected, the bicarb is higher than expected. But I just hate to put a spanner in the works, but just hold on. Okay, there's a small minor thing. It's not a big thing in the conceptual scheme of things, but it affects the numbers just a little bit. Okay, and that is the bicarb. I was talking of this 1:1 model where every anion that's produced is buffered by, or rather every hydrogen ion is, if it's buffered by bicarb. So in a 1:1 model, so when you have a production of a hydrogen ion, the bicarb gets lost by 1. The reality in the blood is that bicarb is not the sole buffer of acid. Okay, you have other buffers, plasma proteins, bone, hemoglobin, and so on. And therefore, the fall of bicarb is slightly lesser because the bicarb is actually spared because it's helped by these other things. So in a 1:1 model, where bicarb is the only buffer of the protons, you'll have a nice linear relationship and it'll fall. So, but in real life, the fall of bicarb is slightly lesser. Okay, therefore, for a single high anion gap metabolic acidosis problem, so for example, if the patient comes to you with lactic acidosis, the delta delta ratio is not expected to be 1, but it's about 1.5. Okay, roughly about 1.5 to 1. That's the usual thing. So the concept is still the same. The delta delta ratio talks about what the bicarb should be, and if the delta delta ratio is higher than expected, then it means the bicarb loss is higher than expected, and so on. But instead of having in your mind, don't think of the delta delta ratio being 1. It should be up to 1.5, 1.6, 1.5, 1.6:1 is normal. Okay. One more spanner in the works. Ketoacidosis behaves differently. So ketoacidosis is a form of high anion gap metabolic acidosis, but not the keto acids are excreted in the urine, which means that because it gets out of the body, it spares all the buffers, which means that the anion gap, the numerator, drops. If the numerator drops, clearly the ratio drops as well. So when you have ketoacidosis, you need not have, even when you have sole ketoacidosis, the delta delta ratio can actually be quite small. Okay, so it behaves like somebody with a metabolic alkalosis because the keto acids get lost in the urine. Okay, right. Now this slide is a summary slide of everything. I've already covered the whole thing. I'm not going to talk over it. You can pause this slide and read it yourself. So the assessment guidelines. Now, if the delta delta ratio is less than 1, you have a combination of a high anion gap and normal anion gap metabolic acidosis. If it's more than 2, you have a combination of a high anion gap metabolic acidosis plus a metabolic alkalosis. And if it's about 1 to 2, about 1.5, it means it's a pure high anion gap metabolic acidosis. Oh, time to catch your breath, isn't it? It's just been that sort of a thing. The last few slides, all about maths, really puts us out of our comfort zone, but I hope it's clear. I hope it's been educational, and I hope it's clarified some things. And if you think about it, you actually never really had a doubt. It's just the maths that put us off, I think. Now let's move on to a couple of other things once we've caught our breath. The first thing is, or rather the next thing is, we'll talk about the osmolar gap in patients with high anion gap metabolic acidosis. And we'll also talk about the specific thing about urinary anion gap in a patient with normal anion gap metabolic acidosis. Okay. So let's cover the concept of osmolar gap. What is this? The osmolar gap is nothing but the measured osmolality minus the calculated osmolality. So what's this again? What's the big difference? What is the calculated osmolality? All of us know that you can calculate the osmolality by sodium, glucose, and urea. These are the main osmoles floating around in the blood. However, when you send the blood to the lab for measuring the osmolality, they will give you an osmolality based on the freezing point technique. Okay, they don't really look at any of these things. They just actually tell you what the osmolality is. They can actually measure it accurately. Normally, the calculated osmolality and the measured osmolality must be almost the same. Okay, because you don't really have anything floating around in the blood apart from these things here. So osmolar gap is normally less than 10. But when you suddenly have an unmeasured osmol, when you have something else that is floating around in the blood, then clearly the gap between the two widens, and that results in a high osmolar gap of more than 10. So what are these osmoles that are floating around in the blood? In other words, when is the osmolar gap really useful? And it's useful mainly in patients with a high anion gap metabolic acidosis. So remember, in the acronym for the causes of high anion gap metabolic acidosis, we came up with this MUD-SLEEPy. Many of these are osmoles. They exert an osmolar effect. All the alcohols will exert an osmolar effect. Okay, so for example, methanol will, okay, ethanol, ethylene glycol, propanol, all of these will exert an osmolar effect. So my acronym for and that's when you have a high anion gap, that's when you have to ask for an osmolality and calculate the osmolar gap. My acronym for the causes of the osmolar gap is MEP-MELC, which is methanol, ethanol, propanol, mannitol, ethylene glycol, lactate, and ketones. Okay. A high osmolar gap will always result in a high anion gap as well, because all of these things that cause an osmolar gap, all of these substances are anions as well. So it will result in increase of unmeasured anions, and therefore will result in a high anion gap. The main role therefore is in the diagnosis of intoxications, particularly alcohol intoxications, as a cause of the high anion gap metabolic acidosis.
Next, let's talk about the urinary anion gap. Firstly, we should understand the physiology of the urinary anion gap. Urine has both cations and anions, and some of these are measured and some of these are unmeasured in the urine, particularly the cations. The major unmeasured cation in the urine is ammonium, NH4+. Now, when is ammonium excreted? It is excreted mainly to get rid of the hydrogen ions. and it is excreted in the form of ammonium chloride. So whenever you have a lot of hydrogen ions, the hydrogen ions get into the urine in the form of ammonium chloride. So the ammonia in the urine buffers this ammonium chloride and forms ammonium chloride. The normal urinary anion gap, the equation for it is the measured urine cations minus the measured urine anions. So just like with any other anion gap, any other gap, it's the gap between the measured cations and the measured anions. What are the measured cations? It's urine sodium and urine potassium. What are the measured anions? It's the urine chloride. Now the bicarbonate in the urine is negligible, and that's why, unlike in the serum where the bicarbonate is part of the anion gap equation, in the urine it does not have to be part of the equation because it's just completely negligible. The normal value of the urinary anion gap is roughly about minus 20 to minus 50. Why? Because see this thing here, the big elephant in the room is the ammonium ion, which is a positive ion. So that is unmeasured. Because you're not measuring the positively charged ion, you have a relative excess of the chloride, and therefore all that is reflected in a negativity. So urine is negative of minus 20 to minus 50 millimoles per liter. Now, what happens in the setting of a normal anion gap metabolic acidosis? What happens to the urinary anion gap? What is the role of it? The main role is, see, remember that normal anion gap metabolic acidosis is primarily, it can either be because of the excretion of excess bicarb, or it can be because of the lack of excretion of hydrogen ions. Okay. The kidneys might be the cause of the normal anion gap metabolic acidosis. For example, when you have renal tubular acidosis and the kidneys are unable to acidify the urine, or the gut can be the cause. So when you have a lot of diarrhea or lower gastrointestinal losses, you can have a normal anion gap metabolic acidosis because of the lack of bicarb, loss of bicarb. So the role of the urine anion gap is to differentiate between a renal cause of the NAGMA, of the normal anion gap metabolic acidosis, and the gut as the cause. So that's the main thing. Is the kidney the cause of the normal anion gap metabolic acidosis? And the principle is, in the setting of systemic acidosis, if the kidney is functioning normally, then the kidney must get rid of this acid. And if it gets rid of acid, it means that it's actually going to generate more ammonium chloride. Okay? So the simple question that we are asking is, in the setting of systemic acidosis, is the appropriate renal response of acidifying the urine, is that working well? That's the question you want to ask. Okay. Now, again, the role of the urinary, how does it actually answer this question? We'll go step by step. In acidosis, the kidneys buffer the excess hydrogen ions by the ammonia and excrete this in the form of ammonium chloride. Okay, that's easy. When you have an extra renal cause of the normal anion gap metabolic acidosis, so when you have a gut cause, for example, the kidneys are working well. What they do is, there is systemic acidosis in the blood. Therefore, the kidneys will try to compensate by getting rid of this extra hydrogen ions from the blood, and therefore they'll produce excess more urinary ammonium chloride. The urine therefore will have both extra ammonium and extra chloride ion. So both extra NH4 plus and extra Cl minus. Now, unfortunately, however, the urinary anion gap only takes into account the extra chloride. It doesn't have room for the ammonium. This is unmeasured. So what happens? There in the equation for the anion gap, there is a relative increase of chloride, and therefore you have more anions, and therefore the net gap becomes a negative number. The urinary anion gap therefore becomes more negative in the setting of normal kidneys. So in the setting of extra-renal causes of metabolic of the normal anion gap metabolic acidosis. On the other hand, if the kidney is actually the cause of the metabolic acidosis, the kidney is not acidifying, it's not excreting hydrogen ions, even normal hydrogen ions properly, then clearly the urinary ammonium chloride is low, therefore urinary chloride is low, and the gap between the measured cations and the measured anions becomes low. Therefore, the urinary anion gap becomes numerically more positive. Okay, so to simplify this further, just think of urinary chloride in the setting of normal anion gap metabolic acidosis. If the urinary chloride increases, then the urinary anion gap becomes more negative. So when does the urinary chloride increase? It increases when the excretion of acid is increased. Therefore, the kidneys are actually appropriately excreting more acid, and therefore the problem that's causing the acidosis must be outside the kidneys. On the other hand, in the setting of the normal anion gap metabolic acidosis, if the urinary chloride decreases, the urinary anion gap becomes more positive. And when would that happen? When the kidneys are not excreting chloride. When does the kidney not excreting chloride? When it's inappropriately holding on to acid in the setting of the acidosis. Therefore, clearly this is a renal problem. So the bottom line therefore is, if the urinary anion gap is more negative than normal, it's an extra renal problem. If it's more positive than normal, it's a renal problem. There is a caveat to all this, just like with everything. When you have an underlying renal insufficiency, there is automatically an impaired excretion of ammonium chloride because of limitation of ammonia synthesis, and therefore the urinary anion gap may remain positive even when you have an extrarenal cause. Okay. Now, the Stewart approach, I have to confess, is something that I don't understand well. Okay, so the good thing with the Stewart approach is that I've palmed it off to Carton Costello, who's a consultant colleague of mine in St. George, and thankfully I don't have to talk about this, so I'm going to skip this slide. So I'm going to come back to unify the whole thing, okay, because I know that it's potentially confusing. So my first step is to look at the pH and determine whether there's an acidosis or an alkalosis. Then I want to know what the cause is, whether it's a respiratory problem or a metabolic problem. And just as an aside, I look at the compensation and decide whether or not it is present, and if it's present, then whether it's adequate or not. Okay, so far it's simple. So this part of it is simple. Next question. If you have a metabolic acidosis, so firstly, how do I determine it? I determine the corrected anion gap. Okay, so I determine the anion gap in every single case and look at and correct it for albumin. And if the corrected anion gap is high, then I look for the acronym MUD-SLEEPY and go down. And if it's normal, let's deal with it in a minute. So if the corrected anion gap is high, then I go through this acronym to find out what the cause is. Then I want to find out if there is a second acid-base disorder, and for that I determine the delta-delta ratio, and based on the delta-delta ratio you can determine whether or not there is a single acid-base problem, or whether there is a coexisting metabolic alkalosis, or whether there is a coexisting normal anion gap metabolic acidosis. I also, in the setting of high anion gap metabolic acidosis, I also calculate the osmolar gap, and if it's more than 10, then I have this acronym called MEP-MELC for explaining that. Okay, so so this part here is about high anion gap metabolic acidosis. On the other hand, if the corrected anion gap is normal, okay, then I look at the urinary anion gap, and if it's positive, it means it's a renal cause, and if it's negative, it's an extrarenal cause. Now, I've called this important notes for the exam, but I guess this is important for anything, okay, for even for clinical interpretation. Just go step by step, and however silly or small, you mention the abnormality, okay? This man has metabolic acidosis, and whether it's mild, moderate, severe, that kind of thing. Okay, quantify the abnormality. Don't forget to mention other things. The patient may have hypoxemia or all those things. And whenever you're asked about this, always bring it back to the clinical arena. Okay, when you're asked a question, just say this patient is sick. He needs supplemental oxygen. He may need immediate ICU admission, etc. Obviously, if the question is very narrow and it says list 4 causes, you're not going to talk about any of these things. You're just going to go bang, 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 bang. But if it's a relatively open-ended question, then bring it back to the clinical arena.